All right, welcome back. I've have a lot of pressure to stay on schedule, so I'm going to do my best. I'm Bernadette Olifola from Loyola, and with me moderating I have Dr. Irina Shaknovich and Dr. Ashley Penton, who is a trainee, a general surgery trainee at Loyola. So let's get started with the 8th abstract for the day. So I'd like to welcome to the podium Dr. Maroney, who is presenting Erector Spinae block reduces opioid use after transaxillary first rib resection. And Dr. Maroney is presenting on behalf of co-investigators at the University of Minnesota.
Hello and good afternoon. My name is Alex Marone, and I'm a second-year resident in the Integrated Vascular Program at the University of Minnesota. Today, I will be presenting our study on the use of Erector Spinae plane blocks to reduce postoperative opioid use after transaxillary first rib resection. We have no disclosures. Recent federal initiatives mandate reductions in opioid analgesic prescribing to control postoperative pain. Transaxillary first rib resections for thoracic outlet syndrome represent an ideal area of focus, as the procedure is associated with severe pain, frequently requiring hospital admission for management. Furthermore, thoracic outlet syndrome frequently affects patients aged 25 to 45, which overlaps with the age range for highest opioid use and narcotic-related deaths. The Erector Spinae plane block is a novel technique which has been highly effective in reducing pain associated with thoracic, breast, abdominal, and lumbar procedures. More specifically, the Erector Spinae plane block has been shown to decrease post-operative opioid usage in breast surgery. The chest wall analgesia from Erector Spinae plane block appears to be particularly well suited for patients undergoing transaxillary first rib resection. We hypothesized that Erector Spinae plane block performed at the time of first rib resection would provide adjunctive analgesia and reduce opioid usage in the post-operative period. We studied all patients who underwent transaxillary first rib resection at our institution from June 2020 to April 2022. All procedures were performed by a single surgeon who serves as a senior author on this study. Beginning in February 2021, all patients received Erector Spinae block at the time of first rib resection, and these patients in the latter years were compared to a control group of patients in the earlier years who did not receive Erector Spinae block. Our primary outcome was postoperative in-hospital opioid usage, which was measured in morphine milligram equivalents, or MME. The block is performed immediately after the incision is closed, with the patient still in the lateral decubitus position. Under ultrasound guidance, the ipsilateral T3 transverse process is identified, and a needle is advanced in the caudocephalad direction until the transverse process is contacted. The needle is placed beneath the Erector Spinae muscle fascia. Correct placement is confirmed by injecting saline to demonstrate separation of the Erector Spinae muscle group from the transverse process. The block consists of a 30 to 40 milliliter mixture of 0.25% bupivacaine with 1 milligram dexamethasone and 30 micrograms dexmedetomidine. Of note, this is a one-time single injection. No catheters are left in place, as some other studies have done. These ultrasound images depict the relative anatomic planes. The arrows in the image on your left are showing the needle trajectory that ends deep to the Erector Spinae muscle. As you can see, the needle goes through the trapezius, rhomboid, and then, of course, the Erector Spinae. The image on the right shows the correct placement of the block deep to the Erector Spinae muscle and superficial to the transverse process. All patients in this study were placed on a standard postoperative pain control management protocol. This consisted of IV Toradol, 30 milligrams every 6 hours while in the hospital, acetaminophen, 650 milligrams every 4 hours, and continuous topical cold therapy. Opioids were given on an as-needed basis and consisted of oral oxycodone or IV hydromorphone as often as every 2 to 4 hours. The electronic medical records were scrutinized to determine patient demographics and operative indications. Postoperative data included opioid use in milligram morphine equivalents and whether the patient was admitted to the hospital or discharged on the same day of surgery. We also documented any returns to the emergency department and any readmissions to the hospital for pain. A total of 50 patients underwent transaxillary first rib resections during the study period. As shown graphically on your right, erector spinae blocks began in February of 2021. The 26 patients before this date who did not receive erector spinae block were compared to the 24 patients who did receive the erector spinae block. There were no significant differences between groups in age, sex, or indication for first rib resection. However, there were more patients in the erector spinae group block who presented with axillary vein thrombosis. Morphine milligram equivalents were significantly lower in the erector spinae block group compared to the non-erector spinae block group with a mean of 21 milligrams versus 64 milligrams. Although more erector spinae block subjects did not use any opioids compared to non-erector spinae block patients, the difference was not statistically significant. 5 of the erector spinae block subjects and none of the non-erector spinae block subjects were discharged on the same day of surgery, which was significant. Following first rib resection, none of the erector spinae block patients returned to the emergency room for pain. In comparison, 6 of the non-erector spinae block groups returned to the emergency room within 1 week of the procedure, which was statistically significant. None of the erector spinae block group patients and 3 of the non-erector spinae block group patients required readmission to the hospital for pain control. This difference was not significant, however. In summary, our data demonstrate that patients who received erector spinae block after transaxillary first rib resection had decreased use of opioids in the hospital, decreased return visits to the emergency room, and reduced hospital admissions compared to non-erector spinae block patients. We conclude that the erector spinae block is an effective adjunct for pain control in patients undergoing first rib resection for thoracic outlet syndrome and helps reduce MME opioid usage in this vulnerable population that's at risk for increased opioid use and narcotic-related deaths. My co-authors and I would like to thank the program committee for the privilege of presenting these data to you today. Thank you.
Thank you. Very nicely presented. I'll turn questions to the audience.
Hey, Man Holston, University of Iowa. Thank you for the presentation. Very nicely done. I'm interested first that some people leave the same day after a rib resection. That's very impressive. We do a lot of supraclavicular at the University of Iowa, and I'm just wondering, would you think that the same block, from pathophysiologic standpoint, would it work on supraclavicular? I know it's surgeon's preference here to do transax, and so I wonder if there's any data on that. The other thing is we do supraclavicular blocks for our surgeries, and oftentimes when they wear out 8 hours later, people kind of hit a wall. I'm just interested if, how long this block lasts and, how people manage it after it wears off.
Yeah, that's a great question. So to address the first part of the question, yes, we did. Our senior author does primarily via the transaxillary approach. I would expect that it should provide similar analgesia based on the mechanism of action. The local analgesia actually spreads kind of to cover the dorsal and ventral rami of the spinal cord, and that's kind of where it acts to indicate this pain. And based on which level you use of thoracic vertebrae, T3 in our case, but you could adjust, more superiorly to kind of adjust for that. It should provide the same level of pain for supraclavicular, but certainly another area to look into. And then the second part of the question, in terms of how long the block lasts and how patients manage the pain, we didn't look specifically at outpatient data, but we can tell from patients who remained in the hospital and that they used fewer opioids, that we essentially believe that it still managed the same with opioid pain control, but at a lower level of requirement than before.
Do I have time? Hi, nicely done. Christina Ryan from Ohio State. I was just curious if you guys looked at the age. So we found that oftentimes our younger patients actually do very well without opioids. And so I was just curious if you noticed that the patients who were coming back for readmission and pain, if they were older than the ones that did not. Thank you.
Yeah, that's a great question. I cannot tell you off the top of my head on that data. I certainly will take another look and look into that. That's a great question. Thank you.
Go ahead.
Rob Thompson from St. Louis. Very nice study, thank you. I wanted to point out that there is published data in the Annals of Vascular Surgery on supraclavicular operations for neurogenic TOS using the ESP block, and we found the same results.
Thank you. I appreciate that. I apologize.
The 2 points I would make, one, when we do this now, and this is our standard approach for all forms of TOS, we do this in the pre-op holding area rather than at the end of surgery. So I was curious if you tried that. And who performs the block when you do it right after surgery? Is that the surgeon or is it the anesthesiologist?
We did not look at it in the preoperative area. I certainly think that's an interesting option. I think we primarily did it postoperatively because the patient is already positioned in the proper position, and the anesthesiologist is the one performing the block. So we'd have to call the block team in. We give them a heads up at the end of the procedure, and honestly, while we're closing, they're usually getting ready, and it's a nice, seamless process.
The last point I'd make is I was a little concerned about the proportion of patients with venous TOS versus neurogenic in the block group, 10-3, and that might skew the results because the venous TOS patients don't have chronic pain prior to surgery, and so they may well have reported less pain, less opiate use anyway.
That's certainly a great point, and something that perhaps further studies, larger studies, kind of looking forward, we can hope to address and kind of better capture a larger group to tease out if that is in fact a factor.
Very nice.
Thank you.
Thanks for the comments and great presentation. We'll move on to the next abstract.
All right,